Thanks, Abrick. Hi, everybody. Nice to see you all again. So I'm aware that this is coming towards the end of the term, and I've picked probably one of the most complex topics to talk about, which is essentially setting up an intensive care in an austere environment. And you'll see I've deliberately titled this "Setting Up a Medical Treatment Facility," and I'll come on to that in a minute. There's a lot of stuff to talk about here. I thought we'd break this down. So what we'd do is we'd define what intensive care actually means. Then this is going to be interactive. I need some input from you guys because it'll help gauge or help you see what's useful from this. So the where, what, and why of what exactly somebody would want to achieve, things that are worth thinking about when it comes to legal considerations of where you're going or what you're doing, the infrastructure of what you need to set up, the personnel required to man it, the medical care that you hope to provide with those personnel, the patient population that you intend to treat, and the logistics required to keep it all going, and the safety elements to consider both for you as individuals and for the patients you're looking after. And then whether or not the end of mission, whether or not it's something that is staying or something that is going to be taken down, and then we'll summarize. So a lot to cover, and I encourage participation. Remember, I can't see you, so if you've got a question, either field it through Abrick on the chat or just turn your microphone on. I have no problem at all with that. So we'll define intensive care first of all, and good old Google, a quick search through the current literature. There's quite a nice little paper here which I found in the Journal of Critical Care from a few years ago that gives essentially it gives an internationally recognized definition of the different levels of intensive care, and I've pinched their definition, which I'll read out to you because I think it's quite good broad overview, which is: intensive care is an organized system for the provision of care to critically ill patients that provides intensive and specialized medical and nursing care, an enhanced capacity for monitoring, and multiple modalities of physiological organ support to sustain life during a period of life-threatening organ system insufficiency. So broad brush, but comprehensive nonetheless. And I think most of you would probably be in agreement that this is what you would anticipate an intensive care bed to look like in many respects, certainly in most UK facilities or developed country facilities. Or indeed not. This is what I would anticipate you would see, something along the lines of. This is an example of a busy UK-based intensive care during the COVID pandemic, just hard at work, just to give you some example of what things may look like. And it is quite different to a ward environment, certainly within the non-austere setting. Even in somewhere like the UK, it can feel quite austere when you go into these environments when they're busy. I think the next thing to think about is what is intensive care capable of. It's capable of essentially three levels of care, where I'm sure many of you heard of high dependency versus intensive care and how many organs you're supporting in a critically injured patient or critically unwell patient. But if you break it down to level 1, 2, and 3, so level 1 would be a facility capable of providing oxygen, non-invasive monitoring, and more intensive nursing care than would be received on a ward. I suspect for most of you guys practicing medicine in an austere environment, your setup, if you're going somewhere, will be looking to base around level 1 intensive care. However, if you're part of a big organization that's well funded with a lot of resources, it may be that you're capable of level 2, which would be where the facility can provide invasive monitoring and basic life support for a short period of time. So that would be arterial lines, that would be ventilatory support, and so on. And then level 3 intensive care is where your facility can provide a full spectrum of both monitoring and life support technology. And it would also most likely be a regional resource for care of your critically ill patients. So a place where other local facilities that have intensive care would want to send their most sick patients to that level 3 environment, and therefore often plays an active role in developing the specialty of intensive care through research and education. So typically a big university hospital would be a good example of level 3 care. So the next question really follows very nicely on from that is, well, what is it that you as an individual can provide? So I think before we go into this any further, I'm just going to take that off the screen for a sec and see if I can see you guys. Please turn your cameras on, and just so I can see and perhaps even pick on one or two of you. I'd be very grateful if you turn your mics on, whether or not you can tell me your current position or things that you're aiming to do in the near future. What kind of medical support with regards to intensive care do you envisage you're going off to do in what austere environment? Daniel, I see you've turned your camera on, so please turn your mic on.
Yes. Hi, Tom. Yes. For me, I'm working in the pre-hospital environment. We do offer ventilatory support. We work in mostly in a helicopter, but also fixed wings. Other than that, I don't know in the pre-hospital setup what more intensive care we would be able to provide. Yeah.
So that's quite a nice opener, actually, Daniel. Thank you for that. I'll come back to some of that in a minute. Emmanuel, I don't know if it's safe for you to talk to us just now. I can't tell if you're driving or a passenger, but if you can turn your microphone on, then please do. You can tell us what austere intensive care you anticipate doing.
So I just packed my vehicle. I work in a teaching hospital at the moment in Ghana, and we have quite an elaborate intensive care unit. I tried to sign up to this course because I work in the emergency department. In my emergency department, sometimes I have more intubated patients than in the ICU because the ICU has limited bed capacity. And so I thought that once I do this, in addition to the emergency practice, and I have always believed that beyond emergency care is critical care. So adding this to my already specialized area won't give me a benefit beyond just the emergency to take care of my patients.
Yeah, okay. Thank you, Emmanuel. Appreciate it. So those are two good examples. I'll move the talk on just now, and I think what I'm about to now talk about will probably answer or not answer, will go in tandem with what Daniel and Emmanuel have both just said. So let me go back to my slides just now for you. I think with the title of what we're achieving from the College of Remote and Offshore Medicine, we're talking about the austere environment. And really, when we say austere, usually we associate austere with elements of discomfort or difficulty, more challenging than one would find, for example, in a typical well-established hospital environment. So I suppose really what you need to think about when we break these things down, for you to set up intensive care in that austere environment, where are you going, first of all? And this can be thought about geographically, such as, are you going up a mountain somewhere? Are you going into a maritime environment? Or are you going to the desert or somewhere frozen cold? Nationally, you could think about, so what country are you going to? Is that a country that's got good infrastructure and logistical support and areas of urbanization or civilization? Or is it somewhere that is totally remote? Or is it a nation that is not particularly stable politically, in which case it may be a conflict zone or a war zone? I think there's always worldwide examples of that pretty much every day. And then environmental. So is this something that is above the waves, below the waves? Is it something that is on its own? Is it in the air? Is it on a ship? Where exactly is it? What is going to influence the thing that you're trying to set up? And we'll come again back to that. There's a lot of overlap between the different sections of this talk, which you'll see, but that helps kind of reinforce this. So the next thing to think about, well, what are you doing? So what is the overall mission that you've gone to achieve? Military side of things is very easy, and a lot of my own experience comes from that, and I'll example that, not deliberately, but just because it's quite a nice way to help you think about things like this. But when it's military support, medical support to operations, a lot of the decision making and why you're even there is not up to me as the individual. It's already been decided by somebody else, from the politicians down to the infrastructure of the military. And actually the medical support aim is then to provide up to whatever level of intensive support for troops going out on combat operations or whatever other military operations are being decided. But that's not the case for everybody. So if you have a non-governmental organization that is sending a medical sort of infrastructure to go and provide a level of care in whatever nation for whatever reason, due to perhaps disaster relief or a country that is torn apart by war or whatever else, then they may come with their own mission. And again, whoever's in charge of that will be able to help you with that. If that's you in charge of it, great, then you know what the mission you're going to achieve is, and you can think about what it is you're doing. Why? Well, it's if you're going as part of a bigger team, then again, some of this may have already been answered for you insofar as the NGO that you're going with, the Red Cross or whatever, are setting something up that may be fairly well-trodden path, actually, and you just need to fall into that machine, essentially, and become a part of it. Again, with the military, that's quite straightforward. My position, I didn't have to make the decisions for this. I just had to turn up, and they even give me the clothes on my back. It was great. Sporting, I think, is quite a good example when we think about the austere environment. Typically, when people want to go mountaineering, mountaineering is an enormously dangerous hobby to undertake, and the medical aspects have been asked to provide medical advice or medical support to mountaineering is, I mean, I don't like heights, number one, but number two, it's hard work because it's a pain in the backside to get up there in the first instance. So anything you're planning, you have to think, how am I going to get that there? How is it going to keep running? And what do I do if it breaks down? Or other. So those are the sort of first considerations you need, really. And again, you could probably predict a few challenges here. If you let's again invite a bit of interactivity here. Feel free to turn your cameras and your mics on. What kind of challenges do you envisage with that? I can give you an example. If you, for example, think about going up a mountain, set up an intensive care facility for a mountaineering expedition in the Himalayas. What are you thinking about? Daniel, your camera's on, so I'm going to pick on you straight off the bat.
The altitude, of course, the logistics of getting your equipment and stuff up there. If you're going to even get personnel to accept to work for you up on the Himalayas. Yeah,
absolutely. Yeah, no, I agree with that. So that's just one environment where you can, without even going into more detail than that, you can already start thinking of a few headaches that you're going to have in planning any kind of expedition in that. And the key there is a lot of planning is going to need to take place. Nelson, your microphone is on. Have you got anything there to add to that? You're all welcome to chip in at this point. If not, we'll move the talk on just so that we don't run out of time. We can always take more input from all of you at the end. And I include Abrick and Winston in that when we get to the end, because they're both of them highly experienced and their opinions would be helpful. So if I come back onto my slides, things that you are thinking of, I think, you know, Daniel quite rightly said altitude. There are some pretty tall parts of the world that you need to think about, and altitude sickness is something that you need knowledge of. There are innumerable specialist training courses that deal with altitude sickness and how to treat it. This particular talk that I'm delivering is not really a clinical talk. It is more to do with all of these other elements and variables when it comes to going off to deliver your medicine. Setting yourself up into somewhere relatively safe in a dangerous environment such as a war zone is something to think about. This is just one of the pictures I took while I was in Afghanistan of a mortar base where again, we can talk about infrastructure support in a minute. The desert environment is just another photograph to give you an example of where somewhere could be considered austere. A situation where you're trying to provide support for something like this, essentially combat operations within either a military or civil setting. Then something like an engineering project that you might have got involved with or choose to get involved with. Typically engineering works worldwide often involves the use of heavy machinery, and I would say from experience can be particularly dangerous depending on the planning that's gone into it and the skill set of the people involved. But if you're providing support for that, then it's always helpful to know what it is they're actually doing, so you can kind of anticipate what kind of illness or injury you may expect. This is an example of a fleet auxiliary maritime capability that we have in the UK to provide up to intensive care level support when the right people are embarked on it. But again, from a civilian aspect, this is a similar kind of thing you could set up on the right platform to deliver mobile care anywhere, so long as it has access to a port or an ability to get patients onto it. So that takes us on to the next thing, the legal considerations. So if you're in your own country and you have an austere environment that you wish to set up, then you'll probably know your own laws well enough to know whether or not what you're doing is legal. If you are going to another country, I think that it is absolutely paramount that you have some knowledge of the law of that nation that you are going to, with regards to the activity you're planning to set up. And it may be anything, just from the permission to go over there in the first place up to the kind of cultural sensitivities of what you're doing, why you're doing it, and where you're doing it, and to whom you are offering that care to. I think if you are part of a bigger organization setting something like this up, you should seek the appropriate advice both from that organization, but also from your embassy if you're moving abroad, well in advance of this activity that you're going to do, and certainly throughout that activity, and maybe even in some cases afterwards as well. Where when you're thinking of setting something up, I think it's also crucial to make sure you've definitely thought about a how you get out plan. Whatever the environment is, give it, be it extreme or austere because of the weather or the location, or whether or not it is a war zone or not, things can go from bad to very bad very quickly in most austere environments. The number of variables that we've already alluded to can change out of your control very quickly, and I think tabletopping that or planning for it is something that you should be very much putting at the front of your mind when you're planning to go somewhere. So let's talk now about the actual infrastructure itself. So we've described intensive care and defined it, I should say. And if we think that, say, level 1 intensive care is probably what most of you would be delivering, so that ability to provide non-invasive monitoring and intensive nursing support to a critically injured patient, more so than you'd find in a hospital ward environment, then what is it that you're planning to set up? Is it going to be something that is tented, so relatively quick to put up? Is this going to be a proper hard standing, so you're going to require the appropriate resources to actually build something that may be permanent or may not be? Or is this literally going to be dealt out of the back of the bag which is on your back? Which takes us to the next thing. Is this particular capability that you plan to deliver, is it static? So is it going to sit there and it's going to stay there for years, or is it going to be there for a short period of time? Or is this going to be mobile? Are you going to operate this out the back of a truck or on board a ship, or indeed on an aircraft? And these are the things that you need to be thinking about when you are planning your ICU. There's a big overlap with infrastructure with regards to logistics, which we're going to come on to later. And in fact, logistics kind of plays into every part of this talk for obvious reasons. But your intensive care that you're going to set up, if you think about any intensive care, it's not designed to hold patients indefinitely. You are inevitably going to be thinking about where those patients need to move next. So a casevac chain. You're also, in order to maintain your facility, going to have to be thinking about how you keep it supplied. And we'll come on to that in a minute. But probably one of the most important things, who's going to pay for it? Because unless you happen to be a philanthropist who's a billionaire, then you're going to need to seek a sustainable source of funding. Now, any of you who plan anything like this with a charity, it may be that you've got an assigned budget that's come from charitable donation. Great. But how long will that last for? Is it sustainable over months or years? It all really depends on who you're doing this with. If this is a military thing, I mean, there's enough evidence in the news at the moment as to what can go wrong with the logistics and planning of any kind of conflict, without going into too much detail. But get buy-in from the people who have got influence on these aspects that we're discussing now if you are planning something. So I think most of us would agree that a typical sort of quick to knock up hard standing intensive care facility will look something like this on the screen. And this is an example of it's actually an operating theatre, but also doubles up as an intensive care bed in Kambasti in Afghanistan. So that is just one example. This is somewhere where you could provide your level 1 intensive care. I don't know if you can see the cursor on the screen that I'm moving around, but towards the top right of the picture, you can just about see a ProPac monitor for non-invasive ventilation. And then on the floor, just behind this yellow bag here, is a suction airway suction device. And there is also an oxygen cylinder, which you can't quite see, that's tucked away down in this little box here, a small oxygen cylinder. So the ability to provide that level 1 support. The nursing element of that would be provided by the clinician who's on the ground. So it's, I suppose, then down to the training they've received to be able to provide basic nursing care for a patient on a 1-to-1 ratio. This is an example of an even more basic tented facility. And although this is a military example, this conceivably could be set up by any one of you, a small 9x9 tent. Again, if you've got the ability to charge up the batteries for a ProPac monitor, or use something like a FEPS generator or whatever to allow you a little element of power so you can light your facility up, and you've got access to gas cylinders, then you could give that level 1 element of care. As soon as you start thinking about higher than that, I don't think that this would be appropriate. But again, other sort of makeshift ideas for your level 1 intensive care can be in the back of an ISO container. Again, either battery powered non-invasive monitoring or something that's connected to a power supply are all the sort of things you need to think about. And again, if it's batteries, then your facility is only as good as until the batteries run out. So you need a way of charging that. So you need to think about that. Again, if it's something that's solar powered, well, guess what? Casualties don't always come in the daytime. They could come at night. Have you got a way of managing that, and so on? This is an example of a locally commandeered, or borrowed, I should say, facility of somewhere that was pretty decent quality little building that had access to water that you can't see in the picture. It had the capability of us getting oxygen cylinders there, and we had a generator to power a ProPac monitor and a suction device. So again, you could provide that level 1 intensive support to a critically injured casualty or critically unwell patient. There was better lighting than the silo-looms. You can see at the top there was actually a light just above where the picture ends. Or is this something you're delivering off your back? Now, I would not have been able to provide level 1 support in 2011 when I deployed, but I am aware of people who now have a lot in the way of portable equipment for non-invasive monitoring, and can stick one of the smaller oxygen cylinders onto the side of a backpack or a Bergen, which on full whack will last you about 15 minutes. So there is an element of the ability to provide level 1 intensive care essentially in the field. And when you're in that austere environment, if you have gone up elsewhere, then that's the sort of thing to think about. This is an example of a maritime sick bay, which again gives you the ability for your level 1 intensive support, both with an examination couch, your non-invasive monitoring, oxygen cylinders, and suction as required, as well as the ability to intubate, but not the ability to ventilate patients beyond the use of the bag valve mask. That was for this type of platform, but again, that's quite similar on a lot of civilian maritime platforms that are of sort of medium to large size that you'll find. And then lastly, we think about that, again, the mountaineering thing. It makes me shudder every time to think about this, but carrying oxygen is really important for the types of patients these guys see, but also for themselves. It's nothing to do with being unwell or not. It's how you get up there in the first place. That's the bit that staggers me, is that these guys voluntarily choose to climb a mountain and expose themselves to this level of risk, which is bonkers. But nonetheless, it's something that you may find yourselves engaged with when or if you're asked to provide medical support. And in fact, altitude sickness is lethal, absolutely lethal. Any of you who've ever done any diving or had an experience with diving sickness or altitude sickness, the ability to put somebody into a pressurized environment, these are really cool. I've seen this a few times. They're called the coffin, and this particular one is a high altitude coffin that you can put a patient into to help with their oxygenation and to try essentially to mitigate their risk of altitude sickness long enough to try to evacuate them off where they are and get them down to the next level or closer towards sea level, and then move them onto another appropriate facility. So that's part of infrastructure. We're deliberately spending a good bit of time on this. There are other elements of things that you need to think about. If you're going to set a facility up, how are you going to get water into that? Is it something that you can easily achieve? Is it, you're going to pipe it in? Are you going to have it brought in bottles? How are you going to resupply that? And that will determine essentially how long you can run for. Will you have a power supply? Will you have a backup power supply? Will that be generator? Will it be batteries? Will it be solar power? Will it be wind? What are you going to do? Toileting, and that's not just for your patients, that's also for you. Where are you going to, or what are you going to do to get rid of sewage? How are you going to eat and drink? That's again both a consideration for yourselves as well as your patients, and how are you going to keep that hygienic and try to mitigate your other environmental risks for diseases such as diarrhea and vomiting. Where are you going to sleep, as well as where are your patients going to sleep, and where or how are you going to maintain temperature regulation if you are somewhere that is extremely hot versus somewhere that is extremely cold. So a little example, when it comes to disposal of sewage, it's all very well to pee down a tube, but if that urine is just collecting in the soil outside the other side of that wall, then funny old thing, you're going to have bugs and rats accumulating quite quickly with that. If that's going off into a stream that's moving off down the wayside, that's great. Just make sure that the downstream element is not where you're taking your fresh water supply from. If you're going to be cooking for yourselves, you have to forgive the younger picture of myself here, but ideally you want to have some way of feeding yourself that is essentially hygienic and is not going to blow your eyebrows off every time you try and make pancakes for your buddies. But that consideration of, you can provide the best intensive care facility in the world, but if you can't feed the staff that then work there and the patients, then it's not going to be much good. Toileting, I think this comes back to what I was saying earlier. If you've got plumbed water or a sewage disposal facility or whatever, then that's great. But if you're setting up something austere, then it's probable that there's not been something there before. So in this instance, it may just be the ability to pass urine and open your bowels to release feces into a bag and then chuck the bag onto an appropriate area to burn it. Whether or not you've got proper water supplied from a well, or whether or not that is then even safe. So you need the ability to be able to test that water and make sure that it's fit for human consumption, that it's not full of contaminants. Similarly, if you've got a large water storage facility to pipe water in, again, you need the ability to be able to test it. And that requires expertise. And that's not something I personally have. These are, again, things you need to be thinking about when it comes to who you're going to send out to this environment. Or this is an example of a maritime hospital environment. This is a sort of nice, shiny, easy to clean environment to keep your patients in for varying levels of support. You can see there's, when upscaled, you can see just on the left of the bed, there's slots to put your oxygen cylinders in. There's plenty, you can't really see the plug sockets here, but there's plenty of plugs where you can then set up your monitoring facilities for patients as required, really. Toileting on board a typical maritime environment facility would include a toilet, a shower, all in one area, which could either be for patients or staff, or both, as required, really. And that's the last sort of picture. Is if you're going to bed a patient down somewhere, again, think about the area. If all you've got is the back of an ISO container with a couple of privacy screens and a mozzie net, then is that really something that you can provide quality intensive care in? And it may be, if that's all you've got, then yeah, that's it. But this comes back to the thought about where you're going to move that patient onto. This is an example of an American intensive facility that had the ability to provide that level 1 intensive support for up to 4 patients at once, but that 4 patients at once would be our absolute maximum, and not for longer than probably about an hour before we'd start getting a bit twitchy about the amount of equipment we'd gone through. You're limited by the amount of oxygen you can deliver, and that's something we'll come on to in a minute. But thinking about personnel, intensive care, when most of us think about it, we think about ITU doctors and nurses, usually lots of nurses because of the ratio of nursing staff required, but we'll go into that in a sec. What is it that you as an individual do? I mean, it's fine if you are, for example, an anaesthetist or an emergency department physician, and you're thinking, well, I could set up an ITU because I've got the skills to do it. But actually, there's a lot more than that goes with it. So who do you need? And ultimately, who's going to then run it? Who's going to be in charge of that? And this comes back to sustainability. You can't just have one person running 24 hours, 7 days a week, because they won't be able to cope with that. So your facility will die a death very quickly. So you then need to have an appropriate roll through of personnel who can maintain that. So this is not a military thing. I would say that any organization that is delivering something of this magnitude would require a chain of command or a hierarchy. So you need somebody to be in charge, whether or not that is remote, and they're then operating their leadership through a nominated person who is on the ground in the location you're in. Whatever the point is, you've got to have somebody who is the senior decision maker for that infrastructure that you're trying to provide. When it comes to the clinical decision making, then that is dependent on the personnel that you are deploying. And if you think about a typical ITU environment, or what may be deployed for something like military operations, you think about skilled personnel, so doctors who are well trained in intensive care and emergency department support, surgeons, so trauma and orthopedic surgeons, which is what I do, plastic surgeons, general surgeons, vascular surgeons, and even neurosurgeons, to provide different elements of what can be achieved in various environments. Most surgeons tend to not really go very far without an anaesthetist. It's pretty difficult to try to operate on patients when they're wide awake. And with all of that, you then require nurses of varying levels. So critical care specialist nurses, surgically trained nurses, and then assisting the anaesthetist. You typically would need an operating departmental practitioner. You need care assistants to help manage the patient's day-to-day needs. A lot of what you want to achieve when it comes to managing the critically unwell people includes diagnostics, so radiology support. That's really difficult and expensive to try to deliver. But again, something to think about. People who can move your casualties around for you, so ambulance drivers, they don't have to be clinically trained, depends on what it is you're trying to deliver. Air crew, if it's people that you need to be air moving your patients off towards the next part of your evacuation chain. Medics, and what I mean by that is your medical assistants, which any of you with previous military experience will be able to attest to, that these guys are essentially a jack of all trades, and extremely versatile and capable individuals, which I've from personal experience found to be just worth the weight in gold. Cleaners, who's going to do it? If it's not going to be you yourselves doing it because you don't have the time, then you need to employ somebody to do that. Logistical support staff, so who's going to bring all the stuff that you're ordering in for resupply, who's going to catalogue it, who's going to keep it safe, and so on. And then everyone else. And there is a plethora of people you could think about for this. So you have to work out where you as the individual are going to fit into all of this when you come to planning what it is you want to do. This is just an example picture of one medical regiment that provided support for close support operations on the ground. So this doesn't even include the hospital support guys. So as a group, we were embedded within various elements of a task force to provide up to level 1 intensive care. And there you can see there's a lot of people there, and that's just to provide for one period of time for about 6 months for a nominated number of UK personnel. So this is an example of an NHS facility for intensive care where, again, this is just for one shift. So you've got a list of different individuals of which you'll have multiple numbers of those different levels. And there are a lot of people involved. So this is something that's not going to be a quick and easy thing to set up in many respects. This is more towards your higher level of intensive support, so level 2, level 3. That takes us on to, well, what care can you actually provide? Because if you can provide up to level 3 intensive care, but only insofar as till you've run out of oxygen after an hour, then that's not really ideal. So you have to work out what it is you're able to do. Do you just want the ability to provide intensive care? Are you going somewhere where you want to be able to do operations on people, which means you need intensive support for them physiologically as they recover from their operation? Or is this to deal with trauma care? Or is this combat, critically injured patients, both civil and military, or what? So the next thing, and this time it's in capital letters, sustainability. How long can you provide it for? Because the best facility in the world, unless you have planned for the different things that are going to be an absolute killer to stop it working, then you're not going to last very long, which means you may not achieve the aim you've set out to achieve. It's always worth thinking that whatever facility you have set up, you will know how many beds you're able to fit patients into. you must be prepared for that system to be overwhelmed. And this is, again, what goes hand in hand with the austere environment, is what are you going to do when suddenly you're receiving more casualties than you've got the ability to provide resource to treat. And NATO, the North Atlantic Treaty Organization, offers a lot of good guidance on this, right down to where you triage your patients into varying levels of unwellness, essentially, in order for you to try to work out what you're going to do with all the busload of people who've turned up unexpectedly. Typically, most of you will be familiar with the idea of the T scoring system of T1 for your most unwell, T2 according to their physiological parameters, and T3 for your walking wounded and dead. But in a mass casualty situation in the military, you need to get command approval to use the T4 category, which is essentially a patient who is alive, but they are expectant. So you're not expecting them to survive, given that you don't have enough resources to share out. And if they were the only casualty you had, then it may be that you can save their life. Or once you've treated everybody else, you go back to them and see if you're able to do something. But again, that's something just to think about. And then something that's on the COROM handbook, which I think is good, and it's something we teach in the UK military as well, is prolonged field care. And that is where you are going to be hanging on to a patient longer than you anticipated, and the things you need to think about how to do that in an austere environment. So some examples of delivering medical care. This was an example of dealing with a chef at sea who dropped a tray on his finger, and a chef's quite an important member of a ship's company. This was for the United States military, where they didn't have a lot of chefs, and this guy dropped the tray and ripped open the back of his finger, and they were worried that he'd taken out one of his extensor tendons, but fortunately I was able to go and stitch him up, and basically he was absolutely fine. He didn't have any issues with his extensor tendons, but we had to make a plan for him in case he did, and to get his wound managed. So although this isn't requiring intensive support per se, it's that ability to think, well, what care can I actually deliver here? Because at that point, I certainly wasn't a plastic surgeon, nor did I have any ability to anesthetize him beyond just local anesthetic. And this is just a very low level thing to be thinking about. But you need to be able to be thinking about from that scaling up in your mind as to what it is that you're going to be delivering. This is an example of a combat injured casualty in Afghanistan around 2009 being treated by the full available surgical team, both US and UK, and it looks like there's a Welshman in the background there as well. A mass casualty or major incident plan is something that you very much should rehearse before you've even undertaken the activity you've gone off to go and do. This particular picture here, I'm able to show you this now because that facility isn't there anymore, so it's no longer a problem. But knowing the location you're in, draw it out, or get a map of the area that you're in, and plan for exactly where you want things, what you want things to be able to do, and what are you going to do as your actions on when you suddenly receive more patients than you can cope with within your facility. And if you've got a facility that can take 50 people, then fine, it's much less likely you're going to have a major incident. But in the austere setting, it's quite unusual that you're going to have capability that's that large. More likely, you'll be talking about the ability to manage intensive or critical care patients, probably in the single figures. So the minute you've got more than that coming through the door, you need to know how to deal with that. The prolonged field care aspect of things that we spoke briefly about there follows a really nice mnemonic, which is something which we teach in the Battlefield Advanced Trauma Life Support, ironically, which I'm actually teaching for the next 2 days of this week. And it follows the hitman. And, you know, we won't go into too much detail now because you've got this in your the handbooks on your website. But this is a really, really good way to be thinking about the sustainability aspect of how you're going to keep going with treatment for your patients. If you are not a nurse and you are on your own and you are the best doctor in the world, that's great. Have you ever wiped a patient's bottom who's unconscious before or after they've soiled themselves? You know, things like that you need to start to think about if you've got patients there for a long period of time. Can you cook? Can you put some food together? Can the patient even eat any food? And if not, how are you going to keep them nourished? Are you able to, you know, mitigate their temperature, strip them down, cool them off, keep them warm? You know, all these sorts of things. If you're on your own, in particular, you may have to think about. And Hitman is just a nice way to break everything down and think about it all. Probably one of the most important things that's covered also with that is writing it down, because whether or not the environment is austere or not, I think keeping a record of what you're doing as any sort of clinician is really important, both for reflection afterwards, but also to make sure you haven't forgotten anything for what you're trying to achieve, and also just to do right by your patient. If ever you come under scrutiny later on for things you've done, if you've kept a record, that's also obviously really, really useful for you. So finally, we get on to, well, who are the patients? Who are you offering the care to? Is this something like military personnel that are deployed? Is this something where you are going to an area to provide care to the local population, so civilians, or is this to elite sportsmen who are doing whatever, or what, you know? Whatever you are going to do, and whoever that population are that you're aiming to help, you must expect there to be the unexpected. And typically, if you've put any medical facility near any form of population centre, I guarantee the local people from that area will start to sniff around, and inevitably people will start to bring you the relatives, the family, the friends, the people of that area, and in particular the children. There are good NATO guidelines on caring for children, but essentially you are not, most of us moralistically are not going to turn away an injured child. And that takes us on to the idea of mission creep. So if you have gone with an aim, for example, you've gone to provide mountaineering support to whatever, let's say a charitable organization is sending you up a mountain to get to the summit of Everest in a certain period of time, great. And whilst you've set up your facility further down, let's say it's one of the base camps, you may have another set of climbers, part of a different charity, who don't have medical support, who are starting to become unwell, and they're not going to walk past you on the way there. They're going to seek the first bit of medical help they can get. Suddenly, you may only have one of those coffin altitude support devices for your own guys, and actually this patient put in front of you may need that. And then you have to make that awful decision of, do I use my resources for someone else who I'm not here for, or do I have to say no, and do I need to keep my resources for the people who I am here for? That is a really tough call, and that is not something that can be taught really on this course. That's something to think about. So if you're managing something very straightforward in your patients, in your environment that you're comfortable with, great. If you are starting to deal with complex things, you need to make sure you've got the capability to deal with it. And if you don't, you need to be thinking about moving those patients on. When I said children in particular, it's very, very emotive to have traumatically injured children put in front of you. And whether or not you've got the facility to manage it, you will always want to do your best as a human being for them. And that is something that you need to prepare for, I think. So that sort of takes us on to the penultimate section of logistics, which is overlaps with everything else we've discussed so far. So you can have a real strong, robust medical team to deliver the aim of what you've gone out to do for intensive medical treatment, but they're only so good as their own energy levels can manage them for. They need to sleep, they need relief, they need time off, and you need to be able to mitigate that. And planning for, depending on the duration of how long you're going to be in your area for, rotation of your personnel is crucial, which means you may need quite a big pool of people to choose from in order to sustain that. Force protection, so you need to find a way to look after yourselves, to look after the people who are with you. If you are part of something that is military, you may attract a lot of unwanted attention, or certainly from a combative perspective, you may come under fire yourselves. So you need to be ready for that, and you need to be in a position that either you can protect yourselves or those around you, or you've got people who can protect you in that area with you. The relevant skill provision we've kind of touched on already, but your evacuation chain is classic for logistics. So if you have intensive care facility for patients for, let's say, up to 24 hours, what are you going to do to move them on? Is this something where you can land move somebody, or air move somebody, or move them off onto a ship to sail them away somewhere? Or is it going to be a combination of all those things? And you can already predict there's a lot of variables that are going to come into that. So the next sort of final thing to consider is your supply and resupply. You could build the best facility in the world, but until you've staffed it and supplied it with all the right people, then it's a complete waste of time. Similarly, you could use all your resources on one patient within a day or two, and if you've got no resupply coming, then suddenly your mission aim is completely invalid because you can't carry on. And that's what you need to be thinking about. So Classically, air supply. If you have got a big, large-scale operation, then you will hopefully have the infrastructure to bring things to you, which means that you need some infrastructure to support landing an aircraft, transporting pallets of equipment to you for resupply. You need to know how long that's going to take. You need to know where the problems are within that setup that you may experience delay, which may then stop you doing things. Road movement, you can anticipate if you are sending a convoy of trucks to get from point A to point B with your resupply, whether or not that's going to be safe. Is that going to be subject to banditry or piracy if it's at the maritime aspect, in which case your stuff might get nicked when it's on the way to you. So how are you going to cope with that? Is it going to be flown in or underslung, in which case is it something that can be transported in such a way? Obviously thinking about how much space you can fill up on an airframe to bring things out to you if it's air supply that you've got. Is it just going to be some mug who's literally throwing things into the back of a trailer on a quad bike to bring things to you to resupply you? We spoke earlier about water. If you don't have piped water in your area or water from a well, if you are literally living out of bottles of water, then you need to know how long that is going to last you, because as soon as you run out of water, you are in real trouble. Particularly in an area of an extreme temperature such as the desert. So a lot of what you're doing is going to be based on that resupply logistics element of things. Gas, if you've got oxygen or Entonox or anything like that, where are you going to store it? You're going to store it somewhere safe. Is it going to be somewhere that is out of direct sunlight? Is it going to be kept chilled? Or, where are you going to put it? This is just an example of a storage facility for oxygen cylinders. And guess what? It gets pretty hot there. So according to the manufacturer's specifications, it's not ideal to store anything above 25 degrees, but sometimes it's impossible. This is an example of, in the maritime environment, I ordered some Entonox once. I ordered 2 bottles and they sent me 28 bottles. So I then had to find a way to firstly safely store the bottles, and then secondly find a way to offload them and send them back down that logistics chain. And that turned out to be a 6-week nightmare. I would never have thought about something like that or planned for it, but it put me into a lot of hot water. And so you have to expect that unexpected. So we've touched on this safety, but we're sort of coming towards the end now. Talking about safety is not just talking about protecting yourself or your patients from physical threats from other people. It's also the environment. Classically, I think if you know you're going to a country that has got diseases that can be vaccinated against, then it would be sensible to vaccinate you and any of your personnel that are going to that environment in the first instance. I suppose other sort of obvious ones would be the use or supply of anti-malarials where indicated. Also, your personnel who are going to provide that intensive level of support to critically injured patients may themselves suffer with their own ailments, headaches, stub toe, diarrhea and vomiting. So that ability to provide primary care for them is something that you need to consider. Personal protective equipment, depending on what you're going to do or who you're with, I suppose. But for example, the support for the Ebola crisis saw military operations delivering PPE for the personnel they were sending out there to protect them from the risk of the disease. And then again, that needs to be something that's sustainable, because if you've run out of the PPE, you can't then just tell your guys to go in without any of that on, because then they're going to contract the disease and they'll be in real trouble. The use of the Red Cross. So again, it depends what you're doing. If you're climbing a mountain somewhere and you need to advertise the fact that you are the medical person, then by all means slap a huge Red Cross on your arm, because then people can see that, and people who are in trouble can come to you for your help without having to try and work out who it is under all of the RAB jackets and sunglasses and oxygen cylinders and so on. But at the same time, the Red Cross can present itself to be something that can get you into difficulty. Unfortunately, you have to remember that if you're, for example, in a conflict zone or an area that's not stable, bad people will do bad things, and a Red Cross is also a massive target. So you need to make the decision as to whether or not you advertise the facility that you set up is something that is medical, to ward off people mistakenly destroying it or attacking it or whatever, versus whether or not you're drawing unwanted attention to yourself that actually may put you at greater risk. And again, that research of knowing where it is you're going and what it is you're doing there would probably be something that's helpful. And the International Committee of the Red Cross, they have doctrinal guidelines as to how or what it is you're going to deliver. They've got a lot of material you can read on their website that's actually pretty useful. And certainly if you're going to work with them, then they're good people to advise on this as well. And then lastly, thinking about those geopolitical factors. If you're going somewhere that is not safe, you need to prepare for that. So the last thing really to touch on is delivering intensive care in the austere environment. Is it going to end? Are you there for forever? In which case, you're probably not going to be there forever, because you'll want to return to your own life at some point. So you need to have a system of handover for the next person coming on, or the next people or team coming out, so that there essentially is a sort of maintenance of the corporate knowledge that's been gained by the facility you set up. If the mission is going to end, you need to work out how to withdraw your footprint of the facility you've established, essentially so you don't leave a terrible mess for the country that's been hosting you. Which comes down to the next thing, respectful departure. So if you're going to leave somewhere, you try and put it back to as it was beforehand, or if it's a facility you can then hand on to a local population, either for repurposing or to maintain what it is that you've been providing, then yeah, that's something you can build into your plan. And probably the most important part of leaving some austere environment where you have done this kind of work is debrief for you and your personnel. So the chance to reflect on what you've done, and the chance to kind of go over the particularly difficult elements of what you've had to do for your own psychological support, I think is extremely important thing to do. Typically critical care and critical trauma care in particular is often very unpleasant things that you will see and smell and hear and experience. And you as an individual need to be robust enough to cope with that, but equally so do the people that you are putting into that environment. And having a way to perhaps manage the psychology of that, or to decompress afterwards, I think is really important and should be part of your planning. So I think we're drawing towards the end of this now. As I said, this is not really a clinical based talk. This is the discussion of a number of variables in different categories to consider when you want to set up an intensive care type facility or a medical treatment facility in an austere environment. So we've defined intensive care. We've discussed sort of where, what, or why you might be doing something. We've spoken about what legal things you might have to think about. We've spoken about the types of infrastructure you might want to provide. We've spoken about who you're going to send. We've spoken about the care you're going to deliver, the patients you're going to treat, how you're going to support all of that, how you're going to keep yourselves and your patients safe, and then how you're going to come to a close on that. And that really sort of takes us to the end of the talk. So if I take, then we're open for questions from all of, or any of you, and any input from Abrick and Winston as they may see fit.
Thanks, Tom. I enjoyed that talk. Really good overview. I think that you've given a good basis for people probably going out on their own and having to work isolated. And I think that's an excellent overview. Thank you.
Thank you, Winston. And Nelson, you've got your hand up. Fire away.
Yes, sir. Tom, thanks so much. Appreciate for the presentation. One of the interesting things that I did find is that after talking about all the setup that you need to do for the ICU in an austere environment, the saddest part that we may encounter is a critical care support or provider is the demise of the people whom you are supposed to provide care for. I know in the military setup, it has got a chain, and it's much easier to handle the death of one staff member and the repatriation of the human remains. But here we are at Mount Everest, and this happens. From your experience, some explanation, something like that? The experience.
Yeah, I think that is. Thank you, Nelson. That is a really, really crucial point, and you're right. That's something I hadn't touched on in the talk, and I think it is important. I think this comes down in part to where it is you're going to be, and if you've got, I mean, yeah, militarily it was easy enough to there was a setup, a logistical setup to fly somebody who passed away back to the nation from which they'd come from. So for UK military, meant coming back to the UK. But if you've got, for example, patients who are dealing with, such as with the Ebola crisis, as an example, you've got patients who've died of this dreadful disease, but then the human remains for them potentially remain infective. So yeah, I mean, that's a massive difficulty that you need to potentially be able to deal with. So culturally sensitive things such as for example, the religion of the nation in which you are and the patients therefore that you're managing who've passed away need to be considered, I think. Also, is it appropriate for what type of burial, if you will, of those patients that you would anticipate, such as burying or cremation or whatever, versus sending the patients back to where they've come from, either to be managed by their own local population or, in the case of an organisation, sent back to the home nation who've put you there in the first place. Yeah, I think you're absolutely right. I think that's a difficult area to cover, actually, and I'd welcome any comments from anybody else on that. But yeah, you definitely would need to think about that.
I totally enjoyed that, and I'm seeing how your lecture is going to perfectly plug into a need that we had within this module. I really appreciate that, and I appreciate that your approach of and your experience of working in austere environments for this situation, or in for a critical casualty. But if you had to carry in a backpack the equipment you needed to provide critical care, what would you carry?
So that's a great question. So compared to 10 years ago, I've seen that a lot of the technology you might need these days for monitoring patients is a lot smaller and therefore a lot lighter than it used to be. I think in today, let's say this is a civilian setting, not a military setting, I would want to have my usual array of things to deal with acutely traumatically unwell patients. So somebody who's bleeding a lot and somebody who may have a problem with their airway, the breathing or the circulation that I can deal with. But when it comes to providing that intensive level of support out of my back or out of my backpack, I'd want the ability to measure pulse oximetry. I'd want a way to check the blood pressure. And ideally, I would want a way to see some form of heart tracing. And there is enough portable equipment out there that I think it's lightweight and sustainable enough that you could probably stick it in the top flap compared to what we did 10 years ago. And I'd say that as a sort of basic level would be reasonable. If it was something that was going, for example, militarily, then usually you've got modules of equipment that are set up for individuals to carry on the back. And if the module is not fit for purpose for things like that, then that's something that you as the clinician can address before you go during the planning phase. And you can augment it with your own stuff for personal sort of preference as well. But then that comes down to what level of care can you deliver. The level 1 intensive care provision is how I envisage most people delivering austere intensive support. And I think that you're not going to get to the point of sticking an art line in someone on the side of a mountain, because what are you going to do with it? You need the ability to measure it on the appropriate equipment, and good luck if you want to stick that on your back or on the donkey or whatever. So yeah, I think that level 1 non-invasive monitoring is a reasonable set of things that you could take with you, insofar as the batteries that you then got to stick in the bag with it to keep the bloody thing running.
Just coming back on this item about the stuff that you cannot carry from every, when you talk about the things that you ought to carry, things like oxygen cylinder that you want to carry, and there are regulations that are there that you may not be able to fly with, and it is considered a dangerous piece of equipment that you are to carry. Now, I know long back we used to have what is called emox. The one that has got crystalloid, then you make it up, then you can use it as a portable oxygen that you can, though it doesn't give that much. I don't know whether that is still around. To those who have been in the field for long, I'm sure you know this kind of piece of equipment that was called emox. I think we used to get it from UK by that time, by those days. Any idea, guys?
I've not experienced the use of that. I've got to be honest. So I've done 14 years of military service, and for my deployments and things, we've always had access to oxygen cylinders, the small ones at least, and some of the bigger ones. I think, if you've got a capability of providing something, I suppose what you have to think about is, are you delivering the level of care that you want to deliver? So if you're trying to provide or emulate, for example, the UK level of intensive support out in the field somewhere, then you've got to decide if the equipment you're bringing is fit for purpose for that. And if that like I said, I'm not familiar with it, but if it's not giving a patient 100% oxygen, then you might argue, well, your preference would be to try to get something else. Now, you're right. If you want to get on an aircraft to go out to the Austere location, then unless it's a low-flying aircraft, you will find some significant obstacles in chucking a load of cylinders in the back. That is definitely something to think about. And it may be that this comes down to, well, how, if you fly somewhere, have you got equipment coming via other means, such as via sea and then subsequently by land? Have you got things in an ISO container? Yeah, you're right. That's a tricky one to plan for. And I think if you're just going to hop on an aircraft with a Bergen on your back that's going to be what you can deliver, then you're right. If you don't have oxygen capability, then in theory you're failing at the level 1 aspect of intensive care support. So it may be that you're providing medical support, yes, but not to an intensive level, in which case you mustn't sort of advertise it as such, if that makes sense. But yeah, it's quite an important thing to think about. Whether or not any of you have familiarity with other things that make up oxygen delivery, yeah, I mean, I'm totally open to hearing about that.
It's interesting you mentioned, hey, Winston, I think you were there in Ireland when we used the EMOX. So it's a chemical. You do 2 chemicals into water, and then it makes oxygen. The problem is at the maximum is about 6 liters per minute. We measured that. So with your oxygen concentrators available now, you can do better than the EMOX. The other problem was heat. So we tried it, and it didn't quite meet the standards. Winston?
Just to make a comment on, if you have a good electricity supply, you can manufacture your own oxygen with oxygen concentrators up to 80% sort of FiO2. So that would be my preferred choice. Because the zeolite that is used to absorb the nitrogen can be just left to one side and it's repleted. So provided you've got a good electrical supply, you can manufacture your own oxygen.
Yeah, perfect. Okay, that's helpful to know. Nelson, does that answer your question at all?
Yes, sure. I greatly appreciate the contribution from everyone. Thank you so much.
Thank you. Are there any other questions or points that anyone wants to raise? I appreciate that it's 6 o'clock UK time, 7 o'clock Maltese time. I don't want to take more of your time than I'm allocated, but equally, I'm totally open. My time is yours if you want anything else.
It's okay.